everyone. Once more, I'm called Vedmir, medical student, University of Montaigne, and I'll be presenting on the white tract and the Corpus Callosum. First, we have our plan, which involves introduction, generalities, descriptive anatomy, clinical application in surgical practice. We have a conclusion and then the references. For the objectives, first, we have to know how to identify the different white tracts in the cerebrum, know the embryology, anatomy, and function of the white tract. I would like to ask everyone to please switch off their mics. Please, can you guys switch off your mic? It's actually really distracting, the noise. Thank you. To continue, we'll have by the end of this lesson, we'll have to know how to know the clinical features of the pathologies affecting the white tracts and corpus callosum, know the application of the anatomy of the white tracts and corpus callosum in surgical practice. We'll start with the introduction, and the introduction will take the embryology of the brain. During brain formation, there are three primary brain vesicles that differentiate into 5 secondary brain vesicles. We have the prosencephalon, which becomes a forebrain. This later develops into the cerebral hemispheres, which contain structures underneath, such as the epithalamus, thalamus, and hypothalamus. This section of the brain is responsible for consciousness, sensory motor transformation, and sensory integration. Next, we'll have the mesencephalon, which becomes the midbrain. This part of the brain undergoes little structural reorganization compared to the spinal cord and other brain vesicles. The third, we'll have the rhodencephalon, which becomes a hindbrain. This part can be further divided into 3 segments. We have the metacephalon. The dorsal grid of this the metacephalon, we have the dorsal grid of the cerebellum, which integrates sensory information to fine-tune output. We have the caudal mesencephalon, which is similar to the structure of the spinal cord with closed central canal of the medulla. We have the rostral mesencephalon. It's called the open part of the medulla. Here we have the cerebrospinal fluid is produced via the choroid plexus and leaks into the subarachnoid space. We'll take now generalities concerning the brain. The cerebrum is the largest part of the brain. It's situated in the anterior and medial cranial fossa of the skull and occupying the whole concavity of the vault of the skull. It may be divided into 2 cerebral hemispheres, which are connected by a bridge of white matter called the corpus callosum. Each hemisphere is made up of a frontal, temporal, parietal, and occipital lobe. Now, going to our topic of today, the white tract of the cerebrum. I would like to ask, have you ever thought how your brain learns information? Suppose you're trying to learn how to write the letter A with your right hand, and after learning, you're asked to write the same letter A with your left hand. Will you be able to do that? The answer is yes. Maybe not with the same precision, but you will know how to do your left hand. So how is it possible that you didn't train your left hand to write the letter A, and yet this information was carried to the other half of your body, permitting you to know how to write the letter A with your left hand? The answer lies in our study of the different cerebral tracts. The generalities. There are 2 cerebral hemispheres, and each of the hemispheres has an inner white matter and an outer gray matter. Talking about white matter, it is made up of myelinated axons of neurons and neuroglial cells. The descriptive anatomy of the white matter of the cerebrum. In order to connect the different regions of the cerebral hemispheres and to other regions of the central nervous system, we need fibers, and that is where the white matter comes into play. We can classify the white matter of the cerebrum into 3 types. We have the association fibers, which are a group of nerve fibers which connect the regions of the same cerebral hemisphere. They are confined to one single cerebral hemisphere. We term it intrahemispherical. Next, we have the commissural fibers, which connects with the regions of both cerebral hemispheres. We term this interhemispherical. And third, we have projection fibers, which connect the cerebral cortex with the rest of the central nervous system. Now, taking each of them, we'll start with the association fibers. Association fibers are nerve fibers that essentially connect various cortical regions within the same hemisphere and may be divided into the short and long association fibers. The short association fibers lie immediately beneath the cortex and connect adjacent gyri. These fibers run transversely to the long axis of the sulci. Next, we have the long association fibers. They are collected into a nail bundle that can be dissected in a formalin-hardened brain. The uncinate fasciculus connects the first motor speech area and the gyra on the inferior surface of the frontal lobe with the cortex of the pole of the temporal lobe. Next, we have the cingulum, which is a long curved fasciculus lying within the white matter of the singular gyrus. It connects the frontal and parietal lobes with parahippocampal and adjacent temporal cortical regions. The superior longitudinal fasciculus, which is the largest bundle of nerve fibers, it connects the anterior part of the frontal lobe to the occipital and temporal lobes. Next, we have the inferior longitudinal fasciculus, which runs anteriorly from the occipital lobe, passing lateral to the optic radiation and is distributed to the temporal lobe. Last but not the least, we have the fronto-occipital fasciculus, which connects the frontal lobes to the occipital and temporal lobes. It is situated deep within the cerebral hemisphere and is related to the lateral border of the caudate nucleus. Our next type of fibers found in the cerebrum, we have projection fibers. Afferent and efferent nerve fibers passing to and from the brainstem to the entire cerebral cortex must travel between large nuclear masses of gray matter within the cerebral hemisphere. At the upper part of the brainstem, these fibers form a compact band known as the internal capsule, which is flanked medially by the caudate nucleus and the thalamus, and laterally by the lentiform nucleus. Because of the wedge shape of the lentiform nucleus, as seen on this section, the internal capsule is bent to form an anterior limb and a posterior limb, which are continuous with each other at the genu. Once the nerve fibers have emerged superiorly from between the nuclear masses, they radiate in all directions to the cerebral cortex. These radiating projection fibers are known as the coronal radiata. Most of the projection fibers lie medial to the accession fibers, but they intersect the commissural fibers of the corpus callosum and the anterior commissure. The nerve fibers lying within the most posterior part of the posterior limb of the internal capsule radiate towards the calcarine circles and are known as the optic radiation. Third, we have our commissural fibers. Our commissural fibers essentially connect corresponding regions of the two hemispheres. We have the posterior commissure, which is a bundle of nerve fibers that crosses the midline immediately above the opening of the cerebral aqueduct into the third ventricle. It is related to the inferior part of the stalk of the pineal gland. Various collections of nerve cells are situated along its length. The destinations and functional significance of many of the nerve fibers are not known. However, the fibers from the pretectal nuclei involved in the pupillary light reflex are believed to cross in this commissure on their way to the parasympathetic part of the oculomotor nuclei. The fornix is composed of myelinated nerve fibers and constitutes the efferent system of the hippocampus that passes to the mammillary bodies of the hypothalamus. The nerve fibers first form the alveolus, which is a thin layer of white matter covering the ventricular surface of the hippocampus, and then converge to form the fimbria. The fimbria of these two sites increase in thickness, and on reaching the posterior end of the hippocampus, they arc forward above the thalamus and below the corpus callosum to form the posterior columns of the fornix. The two columns then come together in the midline to form the body of the fornix. The commissure of the fornix consists of transverse fibers that cross the midline from one column to another just before the formation of the body of the fornix. The function of the commissure of the fornix is to connect the hippocampal formations of the two sites. Next, we have another type of commissure. We have the Habenular Commission, which is a small bundle of nerve fibers that crosses the midline in the superior part of the root of the pineal stalk. The commissure is associated with the habenular nuclei, which as habenular nuclei receives many efferent from the amygdaloid nuclei and the hippocampus. These afferent fibers pass to the habenular nuclei in the stria medullaris thalami. Some of these fibers cross the midline to reach the contralateral nucleus through the habenular commission. The function of the habenular nuclei and its connection in humans is unknown. Okay. Now we move to the most important part, which is our clinical application. We'll take first the projection fibers, and we'll talk about internal capsule lesions. The internal capsule is an important compact band of white matter, as we saw. It is composed of ascending and descending nerve fibers that connect the cerebral cortex to the brainstem and spinal cord. The internal capsule is flanked medially by the caudate nucleus and thalamus and laterally by the lentiform nucleus. The arrangement of the nerve fibers within the internal capsule was shown in our previous diagrams, in our previous slide under the projection fibers. The internal capsule is frequently involved in vascular disorders of the brain. The most common cause of arterial hemorrhage is the arteriomatous generation in an artery in patients with high blood pressure. Because of the high concentration of important nerve fibers within the internal capsule, even a small hemorrhage can cause widespread effects on the contralateral side of the body. Not only is the immediate neural tissue destroyed by the blood, which later clots, but also neighboring fibers, which may be compressed or edematous. Lesions involving the internal capsule, example, lacunar strokes, can give rise to a contralateral hemiplegia of the upper and lower extremities. For example, cortical fiber involvement coupled with certain cranial nerve signs. For example, we have strictly cortical lesions may produce a transient glazed palsy in which the eyes deviate towards the lesion side and away from the side of the hemiplegia. In addition to a contralateral hemiplegia, common cranial nerve fibers in capsular lesions may include: one, we have deviation of the tongue towards the side of the weakness and away from the side of the lesion when protruded. And so we have paralysis of facial muscles on the contralateral lower half of the face. For example, central facial palsy. This reflects the fact that corticonuclear fibers, so genial glucose motor neurons and to facial motor neurons serving the lower face are primary crossed. Interruption of corticonuclear fibers, the nucleus and bugles, may result in weakness of palatal muscles contralateral to the lesions. The uvula would deviate towards the ipsilateral side on attempted phonation. Next, we'll have association fiber lesions. Cortical association pathways or bundles can become disseminated in multiple sclerosis and other demyelinating diseases, leading to cognitive and emotional problems, in addition to sensory, motor, and autonomic involvement that is well known in such disorders. Diminished attention and vigilance can occur with demyelination of association pathways, and that may contribute to some of the memory impairment seen in reporters. Inappropriate expression of emotion and inferior or emotional disinhibition, sometimes called pseudopolar effect, can occur with damage to the frontal association pathways. Both depressive and bipolar disorders occur more commonly in patients with multiple sclerosis than in controls. And there is some correlation with the presence of demyelinating lesions in the temporal lobe, although monoaminergic pathways also may be involved. Although many clinicians view some of these demyelinating plaques that form in a subcortical white matter to be silent lesions that produce no pathology, the endpoint for evaluation usually has been classic motor and sensory symptoms, not emotional and cognitive dysfunction, although such deficits may be more common than previously supposed. The ability of the brain to repair demyelinated lesions often can ameliorate such deficits. Another lesion, aphasia. One important association tract is the Aquifasciculus. The Aquifasciculus is important to language because a large number of its fibers travel from the posterior temporal lobe forward by way of another set of fibers, the superior longitudinal fasciculus, to the motor association cortex in the frontal lobe. Lesions in the area of the Aquifasciculus may cause a major syndrome of aphasia. Aphasia is simply an acquired language disorder caused by brain damage. And then this syndrome of aphasia is called conduction aphasia. There are also indirect aquate fasciculus fiber connections between Broca's area and the parietal lobe, as well as connecting the parietal lobe with Wignix area. Now we'll move to the corpus callosum. The corpus callosum, just generalities about it, is Latin for tough body, for a tough body. It's also called Coronary Commission, and it's a wide, thick nerve tract consisting of a flat bundle of commissural fibers beneath the cerebral cortex in the brain. The corpus callosum is only found in placental mammals. It spans part of the longitudinal fissure connecting the left and right cerebral hemispheres, enabling communication between them. It is the largest white matter structure in the human brain, about 10 centimeters in length and consisting of 200 to 3 million axonal projections. The corpus callosum is a large bundle of more than 200 million myelinated nerve fibers that connect the two brain hemispheres, permitting communication between the right and left sides of the brain. Under the descriptive anatomy, we can see the corpus callosum, the largest commission of the brain, connects the two cerebral hemispheres as we saw previously. It lies at the bottom of the longitudinal fissure. For purposes of description, it is divided into the rostrum, the genu, the body, and the splenium. The rostrum is the thin part of the anterior end of the corpus callosum, which is prolonged posteriorly to be continuous with the upper end of the lamina terminalis. The genu is the curved anterior end of the corpus callosum that bends inferiorly in front of the septum pellucidum. The body of the corpus callosum arcs posteriorly and ends as the thickened posterior portion called the splenium. Traced laterally, the fibers of the genu curve forward into the frontal lobe and form the forceps minor. The fibers of the body extend laterally as the radiation of the corpus callosum. They intersect with bundles of association and projection fibers as they pass to the cerebral cortex. Some of the fibers form the roof and the lateral wall of the posterior horn of the lateral ventricle and the lateral wall of the inferior horn of the lateral ventricle. These fibers are referred to as a tapetum or tapetum, depending on the pronunciation. Traced laterally, the fibers in the splenium arc backward into the occipital lobe and form the forceps major. Lesions of the corpus callosum. We'll start with neoplasms. For example, we'll take the example of anaplastic astrocytoma. It's a rare malignant brain tumor. Astrocytomas are tumors that develop from certain star-shaped brain cells called astrocytes. Astrocytes and similar cells form tissue that surrounds and protects other nerve cells found within the brain and the spinal cord, and this can obviously affect this corpus callosum. Next, have another tumor, the primary central nervous system lymphoma, which is a disease in which malignant cells form in the lymph tissue of the brain or spinal cord. Having a weakened immune system may increase the risk of developing this tumor. Clinical application. We're going to talk about Sussex syndrome. It's a disease, it's an autoimmune disease where autoantibodies attack and damage the endothelium of small blood vessels. It mainly affects the brain, the inner ear, and the eye. The ischemic lesions of the corpus callosum are referred to as snowball lesions. Neurological signs include migraines, confusion, short-term memory loss, gait disturbance, dysarthria, which is slurred speech, psychiatric symptoms as paranoia, personality changes. Next, we'll have Marshava-Bicknami's disease. It's a disease characterized by primary degeneration of the corpus callosum as a result of chronic consumption of alcohol. The disease may occasionally occur in patients who are not alcoholics but are chronically malnourished. Neurological signs are non-specific and include dementia, dysarthria, spasticity, and walking inability. Lesions can appear as hypodense regions of the corpus callosum on tomography and as areas of diminished T1 signal and increased T2 signal on magnetic resonance. We'll have now clinical application in surgery, corpus callosotomy. The major commission is a large corpus callosum. Most fibers within the corpus callosum interconnect symmetrical areas of the cerebral cortex. Because it transfers information from one hemisphere to another, the corpus callosum is essential for learning, discrimination, sensory experience, and memory. Occasionally, the corpus callosum fails to develop, and in this individual, no definite signs or symptoms appear. Should the corpus callosum be destroyed by disease in later life, however, each hemisphere becomes isolated, and the patient responds as if he or she has two separate brains. The patient's general intelligence and behavior appear normal, since over the years, both hemispheres have been trained to respond to different situations. If a pencil is placed on the patient's right hand with the eyes closed, of course, he or she will recognize the object by touch and be able to describe it. Now, if the pencil is placed in the left hand, the tactile information will pass to the right post-central gyrus. This information will not be able to travel through the corpus callosum to the speech area in the left hemisphere. Therefore, the patient will be unable to describe the object in his or her left hand. Sections of the corpus callosum has been attempted surgically with some success in order to prevent the spread of seizures from one hemisphere to the other, like in patients with Lennox-Gastaut syndrome. Next, we'll have the the clinical application in surgery. We'll have the fiber dissection technique in ventricular surgery. Surgical approaches to the lateral ventricle always require passage through one and often multiple fiber tracts to reach their target. These approaches remain a challenge because of the deep location and variable shape and size of the ventricles, their covering mantle of tract, and relationships to important neural structures such as the thalamus and internal capsule. In addition, a number of tracts cause in the walls of the ventricle where they are separated from the cerebrospinal fluid by only a thin layer of ependyma and will likely be exposed to the greatest possibility of damage by hydrocephalus. The fiber dissection technique involves peeling away the white matter tracts of the brain to display its three-dimensional anatomic organization. With that, I want to thank you guys for listening, and the corpus callosum remains the great mediator. Thank you.
Okay, so we've come to the end of the meeting, and thank you so much to everyone that came to attend to this presentation. Yeah, the video and the presentation were shared on our YouTube channel, and we expect more next week as we are going to start a new topic. Yeah, next week we'll be running, that is physiology of the nervous system. Yeah, that will be our next series of topics. Otherwise, we thank you so much, and this marks the end of the presentation and the meeting.